بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. إن شاء الله اليوم هنكمل مجموعة الاميونوسبريشن اللي نستخدمها اليوم في حالات الكدني ترانسبلانت. هنتكلم اليوم على المينتننس immunosuppression medication in kidney transplant patient or post renal or post kidney transplant. احنا هنتكلم اليوم على ادويه المناعه في حالات زراعه الكلى، الادويه التي المريض هيستمر عليها باقي حياته. Before we presented already all safe prescribing medication in all GN. I try to cover all medication you can use in a GN patient, glomerulonephritis. On my aim today to cover all immunosuppression. What most immunosuppression you are using in nephrology, either in transplant or GN. Today, our concentration today in maintenance immunosuppression medication post kidney transplant. We'll start. بسم الله الرحمن الرحيم. قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. بسم الله الرحمن الرحيم. وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. صدق الله العظيم. بسم الله الرحمن الرحيم. إن الله وملائكته يصلون على النبي يا أيها الذين آمنوا صلوا عليه وسلموا تسليما. صدق الله العظيم. اللهم صل وسلم على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. Picture of our Toronto General Hospital, UHN Toronto. Immunosuppression medication, renal transplant. Currently available immunosuppressive agent used in kidney transplant can be classified in 3 categories. بنستخدموا الاميونوسبريشن عموما في اي حاله زراعه، او الادويه اللي بتستخدم في اي حاله زراعه either induction agent and preoperative period during the surgery or during the kidney transplant surgery, and continue after that by maintenance therapy and treatment of rejection. We already discussed the antibody mediated rejection before in one videos in 3 important clinical cases. As regard the induction, I will present later in next videos. Today, I might aim to concentrate on maintenance therapy. This to just correlate this with the last presentation of LGN for safe prescribed medication of LGN, because both near to each other. نحاول نغطي الاميونوسبريشن ميديكيشن اللي بتستخدم في الجين واللي بتستخدمها في الترانسبلانت، وتبقى اوير انت بتستخدم ده ليه والسايد افكت والميكانيزم بتاع كل ميديكيشن انت بتستخدمه. This lecture is going to focus on the maintenance immunosuppression today. Our objective, introduction and agent used for immunosuppression, or for all agent used in immunosuppression post kidney transplant, and a regime used for maintenance immunosuppression. Immunosuppression is special condition for each condition, describe mechanism of action and the usual doses and monitoring, common or important side effect for each medication, and we'll come to that. Our introduction, maintenance immunosuppressive therapy is administered to almost all kidney transplant recipients to help prevent acute rejection and the loss of renal graft. Aim from our maintenance of immunosuppression. غرض انت بتخلي المريض بتاعك على الادويه المناعه ديت، المناعه ان انت تمنع to help to prevent الاكيوت ريجكشن، تمنع رفض الكليه and فقدان الجرافت او الكليه بتاعتك loss of renal graft. The aim of maintenance immunosuppression, the level of chronic immunosuppression is decreased over time. يعني كل ما العيان بيعدي بعد سنه بعد سنتين تبدا تقلل في الجرعات على قدر على يعني بتخلي على اقل دوز وعلى اقل ليفل، بحيث تحافظ على الريسك اوف ريجكشن اند ريسك اوف انفكشن على قدر المستطاع. As the risk of acute rejection decrease to help to lower all the overall risk of infection and malignancy. يبقى انت دلوقتي بتعمل بالانس مع لما العيان بيبقى عدى سنه سنتين 3 4 والكدني جرافت او الكدني ترانسبلانت ستيبل as regard renal function, proteinuria, and whatever, and the vital sign lab, everything is okay. Just try to decrease, but in your mind, but balance between the risk of rejection and the risk of infection or malignancy. So in chronic immunosuppression patient, we are aiming to decrease the immunosuppression as graft and the patient tolerated without any side effect, either rejection or infection or malignancy. The optimal maintenance immunosuppressive therapy in kidney transplant is not established till now. The major immunosuppressive agents that are used in various combination regime. دلوقتي عندنا اهم 3 بيستخدموهم عموما في اي مكان دلوقتي هم الطب بصراحه. الاسترويد نمبر 1، بريدنيزون نمبر 1 بعد البلس استرويد سيرجري، and the MMF either mycophenolate Movitil or coated mycophenolate sodium اللي هو الميفورتيك or الازاثيوبرين. This anti-proliferative group and the prednisone and the anti-proliferative group and the main pillar of this triad is CNI. CNI either using Cyclosporine and Acrylemus. We are using the famous one is Acrylemus. Everolimus and rapamycin and latacept, will come to that later. The main 3 medication now: steroid, prednisone, MMF or myfortic, or azathioprine, and CNI, especially Acrylemus cyclosporine. Usually immunosuppressive agent with different mechanism of action are combining. This therapy minimizes the morbidity and the mortality associated with each class of agent while maximizing overall effectiveness. Approach to initial maintenance therapy. Usually maintenance regime consists of triple immunotherapy, as we mentioned before: CNI, isoftacor or cyclosporine, antimetabolites, azathioprine, MMF, myfortic, and prednisone with also the both of this 3 triad. Outlines. We'll spoke today in detail: cyclosporine, acrylemus, mycophenolic acid, azathioprine, sirolimus steroid. We'll come to all this in details. Classes of maintenance immunotherapy, again, steroid, antimetabolites. We know the steroids as an example. This mechanism of action: anti-inflammatory, promotes anti-cytokines inhibitor, and we'll come to this in details. Antimetabolites like myfortic, azathioprine, each one by his mechanism, and we'll come to that in details. And the CNI will come to that also in details, and other will come also. And this before starting any talk for immunosuppression medication and kidney transplant, you should put this diagram, the 3-signal model of T cell activation. So to clarify this diagram, I will come to that diagram now. This is to simplify for you. This is a graft, and this antigen presenting cell. This will present the antigen to the receptor for our T cells here. This means CD4 cells. And this signal one, this antigen specific, and in comparison by signal 2, this antigen non-specific. The antigen presenting cell 2 presents antigen 2 T cell receptor CD4, and this antigen trigger T cell activation of calcineurin. This شو على هنا بيولع الدنيا في الخلية. ده بيعمل activation للنيفات and this nuclear factor activating T cells, and this will lead to induce or release the cytokines induction, and these cytokines will go to activate this interleukin, including interleukin 2. This will go to his receptor here and activate them by limiters, will go to cell proliferation, and this is a cycle. This signal 1 needs signal 2, and we'll come to signal 2 clarification now. The co-stimulation of signal 1 to activate signal 3. Okay. This to clarify signal 1 and signal 2 also. Again, this antigen presenting cell from graft. This will by activation of major compatibility this by CD4 and T cell receptors. This will lead to anti-triggers T cell receptor activation. The signal ones, but need co-stimulation by this. Signal 1 will not work alone. We need this activation of this signal 2 via co-stimulation between ligands in CD80-86 and CD28. This will help to activate activational cytokines to activate signal 3 and activated T cells. To activated T cells now, you need all signal 1 and the signal 2. I hope this diagram clarifies this. This signal 1 will be fully activated by signal 2 co-stimulation to activated T cells and releases cytokines, especially interleukin 2 for signal 3, as we mentioned before. We'll come to our diagram now. Signal 1 from an antigen presenting cell, major histocompatibility here, and a T-cell receptor C4D, and will join here by T-cell receptor CD3. This will activate calcineurin, but this to be happen, activate calcineurin to activate the NEVAT and enter the nucleus and activate the cytokine release. Need co-stimulation of this signal 2, CD886 and the CD28. This will co-stimulate signal 1 to activate calcineurin NEVAT and the nucleus to release the cytokines interleukin 2 to signal 3 emitters to nucleus again to activate the proliferation and cell cycle proliferation. I hope that clear now. We will come here. This just the site of action of immunosuppression drugs, as we mentioned before. Cyclosporine and Acrylemus will go to this calcineurin inhibitors, and this the stimulator factor, this belatacept will work here. And the azathioprine will go to cell proliferation and the MMF, which will inhibit the emitters here. Azathioprine, this purine synthesis inhibitor inside the nucleus, and the basiliximab will work here, where the basiliximab will work in this interleukin 2 inhibitor. The basiliximab will block this and the CT25, and we'll come to all this in details, yeah, because it's confusing now. These three signals now, as we mentioned, signal 1, as we mentioned, this is antigen specific. Signal 1 here, antigen specific. T-cell receptor, CD3, and major histocompatibility on an antigen presenting cell. Signal 2, this co-stimulatory signal, antigen non-specific, leading to releasing cytokines after activation, both signal 1, signal 2, especially interleukin 2. Interleukin 2 will go to his receptor CD25. This will be inhibited by basiliximab, and this will end if no basiliximab or no inhibition will activate the emitters and cell proliferation. In summary, for our previous diagram, antigen presenting cell will present the antigen to major histocompatibility class 2, to CD4 and CD3, and the calcium and the calmodulin activator lead to calcineurin or phosphatase enzyme activation, lead to dephosphorylation of nuclear factor NEVAT without phosphate group, and this will enter the nucleus to work on DNA transcription and release interleukin 2 and other cytokines. Interleukin 2 lead to activation of emitters, lead to cell cycle proliferation. So C9 act on calcineurin inhibition via binding to cyclovilin by cyclosporin or FK PP as acrylemus. This lead to complex formation with the calcineurin and lead to calcineurin inhibitor and decrease interleukin 2 receptors. This slide summarize all this, what happened here and what happened here and what happened here. Just summarize in this slide, and this is the three signals. Just keep this slide in your mind and this summary in your mind. And it again, this co-stimulation, as we mentioned before. Just to summarize this slide again, I put the last slide. Summarize signal 1, signal 2, and signal 3. CD25. This will anti-CD25 basiliximab will inhibit this interleukin 2 and CD25. It will inhibit the emitters activation here by inhibition and inhibition of cell proliferation. Calcineurin inhibitor either tacrolimus and cyclosporine backbone non-dialyzable. لما حد يقول لك لو المريض حصل له مريض جي ان او مريض على دياليسيس وحصل له جرافت فيلير وكده وبدا يستارت دياليسيس ولسه انت تعمل ويزدرول للمريض، لانه ممكن تعمل له ويزدرول على مدار سنه، او ممكن لو الان هيزرع قريب فبتستمر على نفس الميديكيشن، بس المريض محتاج غسيل. لازم تبقى عارف كويس قوي ان الكالسيورينيسين تاكروليماس اند السايكلوسبورين is non-dialyzable and no dose adjustment with the renal failure. لما العيان بيحصل له مثلا deterioration في الكدني فانكشن ما تروحش تعدل في السايكلوسبورين ولا التاكروليماس، ما بيحصل لهمش adjustment ولا بتعدل الدوز ولا بتدي دوز زياده بعد الغسيل، لان هم ما بيتغسلوش في الغسيل. يبقى السي ان اي دلوقتي تعرف ان هم ايه نون دايلايزابل and no dose adjustment with الكرياتينين كليرنس او السيمتريك جيم فار. think this is the first message for all of my colleagues now. Pharmacodynamics, mechanism of action and side effect of the drug for the body. Pharmacokinetics, effect of body on drugs. This pharmacodynamics, this mechanism of action and side effects, this drug on body. Pharmacodynamics, the effect of the drug on the body and the mechanism of action of the drug. Pharmacokinetic effect of the body on the drugs. As regards the pharmacokinetics, absorption, distribution, metabolism, elimination, monitoring, and interaction. The difference between pharmacodynamic drugs on the body and pharmacokinetics body on the drugs. Okay, I hope that's clear also. This C9 mechanism of action, as we mentioned, with summarize the picture before, I have mentioned antigen presenting cell will present the antigen to major histocompatibility complex type 2 to CD4 and CD3. Calcium, presence of calcium and the calmodulin will lead to calcineurin phosphatase enzyme activation of phosphorylation of NFAT to NFAT without phosphate group. This will enter the nucleus to work on DNA. This lead to transcription factors and the release of cytokines including interleukin 2. Interleukin 2 will go to his receptor CD25 and this will activate the emitters, lead to cell cycle proliferation. So C9 act on calcineurin inhibition via binding to cyclovalent with cyclosporine or FK complex formation with calcineurin inhibition and decrease in interleukin 2. Calcineurin obtained from this Tulipocridium inflatum, this herpes, and this already discovered in 1972. And the first pharmacological paper published 1976 and launched by Roy Kaleni as 1979 and widely used as a triple immunosuppression started to be used officially 1982, but discovered 1972 and started to be used as a triple immunosuppression 1982. 1972 discovered, 1982 start to be prescribed. Calcineurin inhibitor tacrolimus F506 is macrolide obtained from Streptomyces tuberculosis and discovered as 1984 also. 1984 we start to use the cyclosporine. 1984 we start discovered tacrolimus. And then introduced to clinical practice 1987. Just to remember that. Started 1984, discovered, and 1987 used. This 1972 discovered and 1982 used. 1984 we discovered tacrolimus. 1987 start to be used and tested in liver transplant 1989 and remained at the preferred treatment. Used on several other organ immunosuppression protocols more potent than cyclosporine. Toxicity profile already slightly different from that of cyclosporine may safely replace cyclosporine and now increase incidence of PK nephropathy when combined with MMF. The risk factor for hepatitis is now the main pillar of triple immunotherapy now. Calcineurin inhibitors is a phosphatase enzyme and lead to this phosphorylate of regulatory protein NFAT to allow entry into the nucleus. Calcineurin inhibitor bind to specific proteins, cyclovalent, and cyclosporine will bind to cyclovalent. Tacrolimus will bind to FAP. Drug protein complex bind to and inhibit calcineurin. Net result decrease cytokine production and lymphocyte proliferation as we discussed before. This here diagram just show you this cyclosporine and tacrolimus F506 or 506. Cyclosporine here will bind to his cyclovalent receptors, lead to calcineurin inhibitors and inhibition this NFAT activation and cytokine release. FK will bind to his FK receptors, also will lead to inhibition of this calcineurin will lead to both will lead to inhibition of calcineurin, and this will end by no activation of this NEVAT, and this will end by inactivation of T cell and lead to inhibition of release of cytokines. Cytokines here inhibited by C9 either interleukin 2 is the major one and famous one, interleukin 1, interleukin 4, interferon gamma, interferon alpha, and others, and TGF beta expression increased by cyclosporine. This, don't forget that transforming growth factor beta expression will be increased by cyclosporine. This is the issue for cyclosporine, increase interstitial fibrosis in our kidneys. Cyclosporine and tacrolimus selectively inhibit calcineurin. This would by inhibition cytokine transcription and release, which would suppress T cell as well as T cell dependent T cell activation. As we discussed in our diagram before, it will end by suppression of this calcineurin inhibitor, and this will inhibit this cytokine release and activation of interleukin 2 to go to signal 3. Either cyclosporine or tacrolimus is used 90% of kidney transplant recipient in the United States, with tacrolimus being more popular now. I think the famous one now is tacrolimus is preferred because it's associated with decreased acute rejection rate and similar overall cost. Tacrolimus, unlike cyclosporine, does not lower the mycophenolate level. Tacrolimus, unlike cyclosporine. From that, cyclosporine decreases the mycophenolate level, but tacrolimus no. And therefore, relatively lower dose of mycophenolate are needed with tacrolimus. This is another advantage to tacrolimus. With the tacrolimus, I need to give mycophenolate or myfortic with a small dose in comparison to cyclosporine. This is the second key point or home message. Toxicity, tacrolimus has toxicity profile that is slightly different from cyclosporine. Both short and long-term studies in liver and renal transplant recipients suggest that acute and chronic nephrotoxicity of tacrolimus and cyclosporine are similar. Acute and chronic nephrotoxicity are similar. Nephrotoxicity include different arterial vasoconstriction and subsequent decrease in renal blood flow and filtration rate. In nephrotoxicity from what? From afferent arterial vasoconstriction and decrease in renal blood flow and decrease in GFR. This is the main mechanism of nephrotoxicity, especially with cyclosporine. Long-term CNI, chronic interstitial fibrosis, we saw that already with cyclosporine. But nephrotoxicity, what means by nephrotoxicity of CNI, either both, especially common with cyclosporine, afferent arterial vasoconstriction, subsequent decrease in renal blood flow, GFR, and long-term chronic interstitial fibrosis. The second key point or home message from my presentation today. This is a very nice slide for mechanism of CNI nephrotoxicity to show you or to remind you or to keep in your mind. The interesting slide, acute toxicity, reversible with CNI, especially secondary to afferent arterial vasospasm and renal hypoperfusion, decreased GFR. Chronic toxicity, irreversible with chronic renal hypoperfusion, obliterative arteriopathy, focal ischemia, like IFTA, tubular atrophy, interstitial fibrosis, and glomerulosclerosis. The mechanism of CNI nephrotoxicity here, acute, is reversible from afferent arterial vasospasm and renal hypoperfusion, chronic irreversible renal hypoperfusion, obliterative arteriopathy, and focal ischemia like tubular atrophy, and interstitial fibrosis, glomerulosclerosis. And this microscopic picture for patient with normal afferent arterioles and glomeruli and the patient on chronic CNI on the right side, on the right, I don't know the right side. This one normal afferent arteriole and glomeruli, and this patient with chronic. This is the left scanning electric micrograph of the afferent arterioles and the glomeruli tapped from a control animal, and the right side is similar after 14 days of cyclosporine treatment, and this just show evidence of arterial vasoconstriction with preservation of tubular function. This picture after chronic cyclosporine or C9 used. C9 induced hypertension by what? How C9 induced the hypertension? By activation this wink channel. This will end by activation this sodium chloride transporter in distal convoluted tubule, lead to more sodium chloride, sodium reabsorption. Sodium chloride reabsorption leads to hypertension. Calcineurin inhibitor lead to sympathetic nervous system stimulation, lead to vasoconstriction, lead to hypertension. And calcineurin inhibitor also lead to stimulation in the endothelin 1. This is a vasoconstrictor already, lead to hypertension. Angiotensin 2 also lead to vasoconstriction, also hypertension. Decreased nitric oxide lead to decreased vasodilatation and by hypertension. This is just diagram to show how much is mechanism of C9 to induce hypertension. Wink channel in distal convoluted tubule stimulate sodium chloride co-transporter channel distal convoluted tubule, more sodium chloride reabsorption, sympathetic nervous system, endothelin 1, angiotensin 2, and nitric oxide. Decrease dilatation. What is the comparison? I need you. What is the difference between cyclosporine and tacrolimus? Just to go to the most famous one. Nephrotoxicity is common with whom? Here, I put here with steroid sparing, better with FK and rescue المنقذ يعني عندنا هو FK prophylaxis برضه FK هنا CNS toxicity with FK but hypertension common here with cyclosporine and diabetes. I will put diabetes with tacrolimus is more. Diabetes with tacrolimus, hypertension with cyclosporine, gingival hyperplasia is with cyclosporine, and the hypercholesterolemia dyslipidemia with cyclosporine, hirsutism also with cyclosporine, and hair loss with tacrolimus. Okay, that's the main differential. We'll come to that later also. Tacrolimus toxicity of both non-renal toxicity, reported difference in non-renal toxicity with tacrolimus as compared with cyclosporine include more prominent neurological side effect as tremor and headache with tacrolimus. تاكروليمس مور تريمورز. العين لما بيجي لك بتريمورز في العياده تذكر ان هو تاكروليمس مش سايكلوسبورين، ممكن يجي لك بهيدك والكلام ده. More frequent incidence new onset diabetes after transplant, diabetes with tacrolimus, not cyclosporine. Cyclosporine hypertension. More frequent diarrhea, dyspepsia and vomiting. العين اللي بيجي لك diarrhea مع dyspepsia مع vomiting ده مع مين؟ مع التاكروليمس. ومع حط كمان معاهم الMMF. More frequent alopecia or hair loss, this with tacrolimus. Less frequent hirsutism, gingival hyperplasia and hypertension is the criteria of cyclosporine. In addition, tacrolimus, but not cyclosporine, has rarely been reported to induce hypertrophic cardiomyopathy. Tacrolimus, not cyclosporine, will lead to hypertrophic cardiomyopathy and severe neutropenia also. New onset diabetes after transplant, tacrolimus, cyclosporine can cause the reversible toxicity of tool islet cell and may directly affect the transcriptional regulation of insulin expression. So both may increase the risk of new onset diabetes after transplant. Tacrolimus is more diabetogenic than cyclosporine. It already discovered in 2 studies in 2004 meta-analysis found that insulin-treated diabetes mellitus occurred in 10% of renal transplant recipients tacrolimus versus 3%. 10% with tacro versus 3% on cyclosporine based regimen. And the efficacy of limiting toxicity elimination study also elite study. Higher rate of new onset diabetes developed at 1 year in patient receiving low dose tacrolimus, 8.4% in comparison by 60% with low dose cyclosporine, 4.2%. It's a very nice underdose or low dose. Is I think low dose is a difference between both by these 2 studies. Also increased tacrolimus level have a strong association with impaired glucose tolerance and new onset diabetes after transplant. In one study, level high is higher than 15 nanogram per ml. Nanogram per ml is a unit of measuring the level of tacrolimus were significantly associated with the development of glucose intolerance and new-onset diabetes at 1 year. If new-onset diabetes develops, should the patient be shifted to cyclosporine? Generally, affected patients are not switched don't switch from tacro to cyclosporine unless there are other tacrolimus-related side effects. Since the effect of tacrolimus on glucose tolerance may be reversible even if the agent is not discontinued. In one study, for example, 70% white patients and 20% African American were able to discontinue insulin without discontinuing tacrolimus or glucocorticoids. In addition, one large review reported an improved graft survival with tacrolimus therapy despite the increased rate of new-onset diabetes after transplant seen with tacrolimus. Don't message here or tell him message here, don't shift from tacro to cyclosporine. Just keep and observe and dietitian for diabetes control, good education. Try to use low dose as you can. Try to rapid bring your steroid if the graft is stable and the patient is stable and everything. Most of the patient recover and no need for insulin in future. قلنا الفارماكوكاينيتيك والفارماكودايناميك properties of CNI. Pharmacokinetic, this body on the drugs, pharmacodynamic drugs on the body. Tacrolimus, either immediate release or extended release formulation. Prograf, this immediate release, prograf, immediate release, and الادفاجراف بيسموه الادفاجراف this extended release بنسموه الادفاجراف or الاستراجراف whatever. البروجراف عندنا 0.5 1 and 3 and 5 مللي جرام. بيستخدموا بروجراف بيستخدم BID. ده immediate release. البروجراف اللي هو immediate release. and الادفاجراف تستخدم لو انت بتستخدم 0.5 BID هنستخدم 1 مللي جرام once daily advagraph long acting or extended release, and we'll come to that later. We have this also inversus. This inversus also long acting extended release medication, and this we can use if you can't control tremors bile prograph or advagraph. You can use this inversus, or patient difficult to control is using high dose from prograph or advagraph. We can use this inversus. This extended release type of tacrolimus is associated with higher bioavailability and lower peak concentration, and the lower peak, this lead to lower toxicity and a longer time to maximum concentration than immediate release tacrolimus. The switching patient on prograph twice daily to once daily long acting inversus we can use, and this Cmax Cmax per minute ratio percent of fluctuation and the swing were significantly lower and the Tmax significantly longer in tacrolimus long acting الادفاجراف versus inversus versus البروجراف. significant longer. This اللي هي Tmax will be longer here in maximum concentration of the drugs here will be a little bit higher or longer than inversus or long acting medication. This maybe will just avoid any toxicity or tremors or side effect from inversus from prograph short acting or immediate release. Based on this profile, 30% dose reduction for long-acting inversus was observed. Kidney transplant recipient could safely convert it from twice daily to extended release formulation. Studies suggest improved quality of life, especially with regard to moderate to severe tremors experienced by kidney transplant. Improved quality of life and regarded moderate to severe tremors experienced by kidney transplant recipient who switched from twice daily to extended release formulation. But quality of life and the tremors. The tremors improved after shifted from immediate release to inversus this extended release formulation. Tacrolimus dosing should initiate on the first post-operative day. Some center delays the introduction until the serum creatinine decreased by 50% from the pre-transplant value or until the patient has significant urine output. We are here using one dose at least before, especially in a living transplant. We are using one dose before a transplant and will continue either BID or once daily as you're using. If you're using immediate release, we use BID, and if extended release or long acting, we'll use once daily. We are using in a deceased donor, we are giving the first dose post kidney transplant. There is a little evidence that delayed laser immediate initiation of calcineurin inhibitor. This result in lower delayed graft function, because there is aberrant vasoconstriction. Some prefer to use after good urine output, especially with deceased kidney. But in our center with living kidney, you can use one dose for transplant. This will not work, will not affect this vasoconstriction of the aberrant arterioles from the first dose. Okay, at least this will enhance your decrease in hospitalization and you reach your target level of tacrolimus within the third or fourth day and the patient can be discharged home safely. There is a little evidence that delayed or resistant immediate initiation of calcineurin result in lower rate of delayed graft function. The KDIGO guidelines recommend that administration of CNI should not be delayed until the onset of graft function. Another recommendation. Tacrolimus is a dose you will calculate 0.1 to 0.2 milligram per kg per day, divided in two doses if you use immediate release or once daily if you use Advagraph or Inversus. Usually we are using Advagraph here, long release or extended release. 0.1 to 0.2, usually just we are calculating on 0.1 milligram per kg per day and adjust according to level. Most clinicians start at a lower end of dosing range and adjust based on drug concentration. You can start 0.1 milligram per kg per day and you can adjust level later according to level. Tacrolimus level, C0 trough level. Tacrolimus, don't forget C0 trough level. This dose should be taken 30 minutes before morning dose. 30 minutes before 30 minutes to 1 hour. It will be dated for our nurse, 30 minutes to 1 hour before the morning dose. C0 tacrolimus, you should depend on that level, not C2. A new study, early versus delayed tacrolimus initiation, another new study published 2018, done to find the relation between acute rejection before 90 days and the early beginning of tacrolimus, where about 298 patients were involved. Tacrolimus has been effective in reducing pyroxyprofen antibody-mediated rejection or antibody-mediated rejection within the first 90 days. But tacrolimus has effectively using the pyroxyprofen antibody-mediated rejection within the first 90 days. أول 3 شهور. tacrolimus تبدأ بدري أحسن عن بدل ما يديله antibody-mediated rejection. It's administered before 7 days after transplant surgery. Every day tacrolimus administration is delayed. There is a 2% increase. Oh my God! Every day tacrolimus administration is delayed. There is a 2% increase in the probability of developing pyroxyprofen antibody-mediated rejection. This is the second important critical home message for you. Don't delay tacrolimus. Just start. If you have living, just start to give one dose before surgery and continue according to are using immediate release or long acting. If disease does start direct after the surgery, you can use disease after surgery direct from the day zero, or you can use from day 1, no problem. Tacrolimus monitoring using a 24-hour, and I'm using the this one. 12 this maybe if I'm using Prograph or immediate release on ID. If you forget to take C0 before morning dose, you can take C0 also before a night dose. If the patient taking on PID for immediate release or short acting, the patient on Advagraph just to take morning 30 minutes or 1 hour before morning dose C0 tough. Concentration is the best for immediate release and extended release according to application available in your center. The blood concentration should be checked 2 to 3 days after starting tacrolimus, 2 to 3 days. From second day or third day, you should check tacrolimus, and after each dose change. This is a second, or this is another home message or key point. If you will change the dose, you should check tacrolimus. If you will start the tacrolimus, you should check by second or third days. I think the effect will appear, and you should change or decrease or increase according to the tacrolimus level. Patient who receive ATG for induction therapy, our target will be 7 to 10 nanogram per ml for the first months after transplant, and 3 to 7 in subsequent months. But we have one study, the high rate of rejection if less than 5. Better to keep your patient around 5. 4 is okay, 5 is okay, 6 is okay, 7 is okay, like that. In chronic patients, especially in chronic patients, keep your patient 5, 6, this will be better for him. Now, don't forget 7 to 10. If you are using ATG, polyclonal depleting antibodies, aggressive immunosuppression medication, we'll discuss this in next presentation. Your target 7 to 10 nanogram per ml for the first months after transplant, 3 to 7 nanogram per ml for subsequent months. In patients who do not receive anti-lymphocyte depleting agent for induction therapy like Ziliximab, just monoclonal antibodies, just deplete all activated T cells. You keep your target from between 8 to 10 nanogram per ml for the first 3 months, and subsequent transplant, subsequent months 3 to 7 nanogram per ml for subsequent months. After discharge, the patient monitor attack level. After discharge, the patient just monitor attack level once or twice weekly. After discharge from recent surgery, monitor attack level once or twice weekly for the first month, then weekly until the third month post-transplant. After discharge, you will follow it once or twice weekly. At least we'll do twice weekly for the first month, then weekly until 3 months after that, after transplantation. Then every 2 weeks until 6 months post-transplant, and then monthly after that. Stable low-risk patient may have their TAC level monitored every 2 or 3 months. After the chronic patient, maybe 2 or 3 months, that would be okay. After causing variable tacrolimus level between subject, race, and ethnicity, Hispanic and African American subject have less mean tacrolimus exposure than Caucasian. And this has regarded the cytochrome P3A5 gene difference among different ethnic groups. Most subject of Caucasian population, around 90%, are cytochrome B homozygotes, and slow calcium. This patient have slow calcineurin inhibitor metabolizer, slow metabolizer, need a small dose. A study published recently, 2018, in Biomed Research International, addressing which patient group may benefit from initial dose reduction. It was found that recipient age found that the recipient age, body mass index, hemoglobin, and the presence of hepatitis C antibodies are independent risk factor for potentially toxic tacrolimus wall blood through the level after kidney transplantation. In older patients, the increase on the drug distribution, lipophobic drugs, the decrease in the liver mass and the hepatic blood flow together reduce the cytochrome P3A5 activity, all may contribute to high first TAC level blood level in older age patients. It's also a home message or key point here. Body mass index more than 24 also resulted in high TAC blood level, mainly due to altered body fat mass in those patients. Other factor, hepatitis C, also associated with the high TAC level also. And the initial tacrolimus dose reduction or lower target tacrolimus level should end in the first few months in kidney transplant recipient age 55 years or older, who is overweight or obese, a patient with hepatitis C. Please just to try to lower the dose as soon as possible, otherwise we'll go to CNI toxicity. Cyclosporine is available in non-modified like Sandrimion or neural formulation as a trade name. Modified cyclosporine is unique microemulsion formulation, miscible in water, and had improved pharmacokinetics, bioavailability, and less intra and inter-individual variability when compared with the standard non-modified oral preparation. Most intra-administered modified cyclosporine because is equivalent efficacy and more convenient administration with monitoring compared to non-modified cyclosporine. Caution should be taken when switching between formulation due to variation in bioavailability, and which can lead to toxicities or underdosing and subsequent rejection. Dosing cyclosporine oral 6 to 10 milligram per kg per day. Every 12 dose divided every 12 hours, available in 25 milligram tablet or trough level or C2, better to take C2 level, and I will show you now because maximum drug concentration and area under the curve will be within 2 hours. If you will give patient in ICU or post-surgery, or you need to give IV, give the third oral dose, third dose of oral. For example, if I have patient 150, I will give him 50, either IV once daily or maintenance infusion, 50 milligram. This you will give a certain dose when you will shift the cyclosporine from oral to IV, post-surgery, post-ICU. Acrylemus, we have the most famous one, Prograf and Advagraph, 0.1 to 0.2 milligram per kg per day every 12-hour dosing, or 24-hour for Advagraph. Higher dose required with Advagraph, available in 0.5 and 1, 3, 5, whatever. You will check, as we mentioned here, C2. We can check C0, C2, but C2 I told you is better, but C0 trough level here is better with the Acrylemus. Cyclosporine dose, as we mentioned, 6 to 10 milligram, as we mentioned. And we'll come to this regard the trough level or 12 hours trough level should be monitoring. The target level should be progressive decrease over time of transplant from 200 nanogram per ml during the first year to 50 to 75 ml long term. Just put in this in your mind, maybe around 200. You'll check trough level around 200 in the first year. Maybe after that 50 to 75 trough level or C0 level in cyclosporine, this will be okay in chronic transplant patient. Therapeutic drug monitoring used when there is a narrow therapeutic index, especially in our drugs, CNI, highly variable drug concentration between and or within patient for a given dose, good relationship between drug exposure and toxicity and efficacy. Sampling is a good surrogate for drug exposure. Drug level over the course of dosing interval. Here we have 0 level here at C with 0 maximum or 0 max of the drug level here or trough level. When we will give tacrolimus or cyclosporine, we just will give tacrolimus, the peak of the drug concentration will appear here within 2, I think, will go here within 2 hours. If you check 2 hours, 3, 4, 4, and this will end by, it will decrease around 12 hours. If you are using Prograf BID dose, from 1 hour to 2 hours, and after that will reach to 0 again, you should give a second dose here. Or you check the trough level here. Before the second dose by 30 minutes, you can check trough level. Or here, you can check the trough level also. But this C2, you should, C2 after 2 hours, you will find the peak here. I think C2 will give you the good concentration of the drug after intake the drugs per oral after 2 hours. But we are depending on a C0 here to check what is the best level here, not the peak level. I don't like the peak level. I need the best concentration of the area under the curve for medication to adjust or increase or decrease. And regarding the cyclosporine, each line here means one patient, this one patient, this one patient, this red one, this. We'll see here, the problem here in cyclosporine in comparison by tacrolimus big variability or huge variability between the persons, and according to their age, ethnicity, whatever. If one person and this one person is high peak of toxicity and this low peak of toxicity, this is another disadvantage of cyclosporine. And as regards the CT monitoring for cyclosporine, CT is the best predictor for area under the curve between 0 to 4, as we mentioned here. 0 to 4 here leads to higher dose early post-transplant, lower dose late post-transplant. With another C2 monitoring for cyclosporine, and this is table just to show you a cyclosporine level target patient without induction with basiliximab interleukin-2 receptor antibody inhibitors, or thymoglobulin monoclonal with immature or without immature. All this just if you can read later, no problem. Just we'll go to basiliximab. The first 3 months more than 1,500. 600 to 1,000, 3 to 12 months, and around 800 and more than 12 months. This was the LTG from 1,000 to 1,200, 600 to 1,000, 800. This as regard the C0 or C2. He mentioned here C2. We mentioned C2 the best measure for cyclosporine, and C0 for tacrolimus. You can read this, take a picture, and you can read. Patient non-induction therapy, keep your cyclosporine C2 in this. If a patient with basiliximab or interleukin-2 receptor, you will keep your C2 here, and ATG will keep your C2 here. And this tacrolimus from without induction, with basiliximab, with ATG, with or without immature, just to keep this in your mind also. Side effect: acute decrease in LGFR vasoconstriction, thrombotic microangiopathies common with CNI, chronic non-progressive decrease in LGFR, chronic progressive decrease in LGFR, chronic IFTA from transforming growth factor beta, as we mentioned with the cyclosporine, hypertension with cyclosporine, sodium retention from activation in wink channel and distal convoluted tubules, tubular dysfunction, hyperkalemia, hypomagnesemia, hypophosphatemia, hyperuricemia, because this already you will see all this post-kidney transplant, because the tubular regeneration will take some time. And interactions, there are numerous class of drugs that interact with C9, either by inhibition or stimulation of cytochrome P4 or 450 system. And this is acute C9 toxicity. Just will show this facularization of no other finding of rejection. This will blame this biopsy for this clear facularization here, clear in our tubules. This acute C9 toxicity. Chronic C9 toxicity you will see the middle area or strips of interstitial inflammation, tubular injury in comparison by normal tubules. This criteria for chronic C9 toxicity, and the chronic vascular changes as we see here, hyalinosis, and side effect as we mentioned, hyperlipidemia. We'll see in cyclosporine more, hyperglycemia, tacrolimus more, hirsutism, cyclosporine more, alopecia, tacrolimus more, neurotoxicity, headache with tacrolimus. Headache means cyclosporine from hypertension, but it tremors mainly tacrolimus. Mental status and reversible posterior leukoencephalopathy from being out cyclosporine, and infection with malignancy, also the common complication, the gingival hyperplasia. This was cyclosporine already, and this white matter, the hypodenesis, reversible leukoencephalopathy with the C9 also. We are seeing this before, and this withdrawal medication. Drug interaction, drug decrease the level, anti-tuberculous, anti-epileptic. Don't forget this, anti-tuberculous and epileptic will decrease the level. We need high doses, but other statin also, amyloid amphotericin also will increase the doses. Sirolimus also will combined by this C9 will increase the nephrotoxicity. Increase the level calcium channel blocker, antifungal. If you fluconazole or ketoconazole or whatever, this will increase the dose. You should increase this dose by half, by 50%. Macrolide, erythromycin, whatever, this also will increase the level. Protease inhibitors and grapefruit juice already will increase the level. To mention erythromycin, this will increase the level. Antifungal will increase the level. Diltiazem verapamil also can use an antihypertensive or rate heart control. This will increase the level. protease inhibitor antiretroviral medication, this will increase the level. Drugs, anti-tuberculous and anti-epileptic, this will decrease the level. And it was inducer for cytochrome, but this all inhibitor for cytochrome. Cytochrome B450. This inducer, anti-tuberculous and anti-epileptic. Okay. Anti-metabolite agent, mycophenolic acid and azathioprine. Mycophenolic acid, this is a reversible inhibitor of enzyme monophosphate dehydrogenase. Don't forget that reversible inhibitors of enzyme monophosphate dehydrogenase. Don't forget this enzyme, a reversible inhibitor of enzyme monophosphate dehydrogenase. This will lead to inhibition of mTORs, mammalian target of rapamycin, and we'll come for that. And cell proliferation, okay? And this 5-ribosyl pyrophosphatase, this will lead to enzyme monophosphate pyrophosphatase, and this enzyme monophosphate dehydrogenase lead to GMP and GTP and will end by DNA. All this will be inhibited if you will inhibit this enzyme, a reversible inhibitor of enzyme monophosphate dehydrogenase. Required this for purine synthesis, for DNA synthesis. This enzyme, and don't interfere with the salvage pathway. Also has activity against B cells also. Azathioprine, these prodrugs of 6-mercaptopurine, purine analogs prevent DNA synthesis and de novo purine synthesis also. Mycophenolate already discovered 1977 and FDA approved 2004, lately approved. And this 6-mercaptopurine, that's azathioprine included, this prevent DNA pathway. This mycophenolate Movitil, already penicillin related, introduced in 80s and the clinical trials early 90s, and then started to be replaced the azathioprine as a routine in the early 2000. And the mechanism of action, where is the mechanism of action of this mycophenolate Movitil? In this enzyme monophosphate dehydrogenase inhibitors. This will inhibit this, all will end by this cell cycle proliferation, DNA synthesis, all inhibit all this cascade already. Anti-metabolite agent interfering with the synthesis of nucleic acid and inhibit proliferation of T and B cells, and so suppress both cells and the humoral immune response. And we mentioned before, this emitters here will be inhibited, and this will lead to the mechanism of action of mycophenolate here, and this will lead to cell cycle proliferation inhibition. Also, MMF here as will be metabolized half-life around 12 hours. بيتحول إلى mycophenolic acid is active form by this enzyme glucoranoltransferase. This will end by this inactive form. This inactive form will be secreted in urine, and the peri will be recirculation again by this bacterial glucuronidase, and will transfer to active form. This with tacrolimus, but not with the cyclosporine. So we need high dose of cyclosporine because this mechanism. With the active form transfer to inactive forms will be secreted in urine and the peri, but with tacrolimus, this form will be recirculated again to active form. This will not happen with cyclosporine, so we'll need high dose with the cyclosporine. Azathioprine, this it will be transformed to a 6-mercaptopurine. If you use allopurinol, this will inhibit transformation of this mercaptopurine, and this will lead to accumulation and toxicity. Will not be transformed to 6-uric acid. And if you have this enzyme TBMT, purine methyltransferase, TBMT, you should be screened before azathioprine. It's also 6-mercaptopurine or mercaptopurine will not be transferred to methyl-mercaptopurine. Otherwise, if you are using allopurinol or hexancine oxidase inhibitor or thiopurine methyltransferase, it will inhibit this mercaptopurine transformation and will lead to accumulation of this mercaptopurines and toxicity from that and severe myelosuppression. Availability is 50%. Dose just usually we are using 2 milligram per kg once daily, and you can follow up by CBC and adjusted with that non-dialyzable also, as we mentioned before. C9 non-dialyzable, azathioprine non-dialyzable, MMF non-dialyzable. And non-renally excreted, no no monitoring. It's only CBC and liver function test. You should be monitoring maybe twice weekly after using. mycophenolate 1 gram BID. This is a common dose, and the enteric code that we are using is Myfortic 720 BID, derived from trials with cyclosporine low dose with tacrolimus azathioprine, just 1 to 2 milligram per kg per day as a azathioprine, and the IV dose will give half an oral dose in azathioprine, give half a dose. Mycophenolate Movitil group added to prevent breakdown on the stomach. We have Celsate MMF available in oral IV formulation, enteric coded Myfortic. Enteric coded we are using in patient can't tolerate MMF. Most transplant center administered mycophenolate as an antimetabolite agent to renal transplant recipient rather than azathioprine. This consistent with KDIGO recommendation clinicals 2009, which suggests mycophenolate as a first line antimetabolite agent. If the patient can tolerate, will go to azathioprine after shifting from MMF to Myfortic or Celsate to Myfortic. If still untolerated, will go to the azathioprine. Despite its increased cost, mycophenolate is preferred over azathioprine because of superior ability to prevent acute rejection and better side effect profile. So mention we have this Celsate mycophenolate Movitil form and the Myfortic this enteric coated form. And the problem of toxicity, GI intolerance is a problem for this patient, frequent diarrhea, and not non-related to local effect, not clearly related to mycophenolic acid area under the care, nausea, vomiting, esophagitis, gastritis, diarrhea, no real difference between formulation. Hematological, don't forget leukopenia, thrombocytopenia, anemia, pancytopenia, especially leukopenia with mycophenolate, less common than with azathioprine. Congenital malformation, contraindicating pregnancy or childbearing females, or you should don't forget to inform your female if you need to use contraceptives if it's childbearing period. And mycophenolic acid exposure increase during the first year post-transplant, affected by renal function, serum albumin, choice of C9. As I told you, mycophenolic acid will be recirculated from inactive form to active form with the tacrolimus, but with this recirculation will be inhibited with the cyclosporine. As we mentioned before, we need high dose with cyclosporine and low dose with tacrolimus. Suggested mycophenolic acid exposure 30 to 60 milligram per hour per liter of effectiveness, but not for toxicity. A conflicting result of randomized controlled trials, therapeutic drug monitoring of mycophenolic acid, not standard care. Azathioprine toxicity, as we mentioned, myelosuppression, severe bone marrow depression, hepatitis, don't forget to follow CBC, and liver function test maybe twice weekly. Cholelithiasis, pancreatitis also, as mentioned in you found high amylase lipase, don't forget azathioprine as a cause of pancreatitis. Interaction with allopurinol, if you use allopurinol, decrease the dose of 50% of azathioprine, reduce azathioprine by 50%, not 25%, monitor CBC or white blood cells weekly for leukopenia. MMF and the coated similar in efficacy and safety. Persistent diarrhea is the most frequent adverse reaction to mycophenolate, is the principal reason underlying dose reduction or discontinuation, and this has been associated with an increased risk of rejection and allograft failure. However, mycophenolate sodium and enteric coated formulation of mycophenolate was developed in an attempt to improve the gastrointestinal tolerability of mycophenolate. Some, but not all, studies have found that enteric coated mycophenolate product with fewer GIT side effect, multi-center trial in which patients with significant gastrointestinal complaint with MMF were converted to coated mycophenolate sodium, resulting in significantly decrease in GI symptoms and improve overall patient well-being. Similar findings have been observed in other studies. MMF-induced diarrhea, and recent systematic review to study clinical features and outcome of mycophenolate Movitil-induced diarrhea, it was found that MMF-induced diarrhea generally present with watery diarrhea. MMF-induced diarrhea generally present with watery diarrhea. The presence of bloody stool should raise the concern of other possibilities. In MMF, watery diarrhea, not bloody stool diarrhea. Okay, this is another home or key point. The latency period can range from months to years. Since a long latency period does not exclude the possibility of MMF-induced diarrhea. A vast majority of patients respond to cessation of MMF or dose reduction with a few weeks. However, cessation of MMF may result in graft-free rejection. We can cut the dose or separate dose from, for example, 1 gram BID to 500 QID every 6 hours, and or PID or BID, or shift to azathioprine later. In case where continuation of immunosuppression is considered important to prevent graft rejection, alternate management option of MMF-induced diarrhea include switching the patient from to another enteric-coated form that each 250 milligram MMF equivalent to 180 milligram enteric-coated form, or initiation different immunosuppression if is not still intolerable, will go to the azathioprine. Another study published recently in journal American Society shows that when severe diarrhea occurs in recipient of a kidney or kidney pancreas transplant, the most common infectious causes must first be excluded. You should exclude infections. Don't blame only MMF just to go to rule out virus infection, especially norovirus. Needed norovirus. Norovirus is a common cause of diarrhea post-kidney transplant need to be looked for, as this infection is becoming increasingly appreciated as a cause of severe chronic diarrhea requiring the reduction or a change in immunosuppression to achieve resolution. A colonoscopy with biopsy should always be performed when an initial evaluation is negative to look for colitis, to exclude CMV colitis, lymphoma, CMV gastroenteritis involvement may occur in the absence of CMV viremia. When infectious causes are excluded with reliable testing, one need to consider entity of mycophenolic acid-induced colitis or small intestinal villus atrophy. And this should be considered in your mind also. The diarrhea and associated malabsorption in such cases often require complete discontinuation of the drug with the substitution of azathioprine in most patients to reduce the risk of rejection. In addition to GI absent, mycophenolate also cause leukopenia. Don't forget, there's one of the differential diagnosis of leukopenia post-transplant 11.8% to 40%, around 40% of kidney transplant recipient. Other manifestations include anemia, thrombocytopenia, and pancytopenia also, which is frequent cause of dose reduction. Consider reducing the dose or holding MMF temporarily. It also suggests to reduce dose or hold the anti-CMV medication temporarily, like Valgan cyclovir. This is a cause also of leukopenia, and don't forget pantoprazole also cause of leukopenia. You have pantoprazole can do leukopenia, you have Valgan cyclovir can do leukopenia, you have MMF can do leukopenia, you have Ciptar also can do leukopenia. In case of ATG or almituzumab induction, you may consider reducing the dose of MMF initially. This may prevent the occurrence of hematological cytopenia. Mycophenolate Movtil 1 gram PID started preoperative, peak after 1 hour. Mycophenolate sodium 720 BID, peak 2 to 3 hours. Some update reference suggests that mycophenolate dose may be reduced to 500 BID or 360 BID in enteric-coated form once Cyclosporine reaches to therapeutic level. If cyclosporine is used as a TNI, then the maintenance dose of mycophenolate should be a higher dose, 1 gram, and don't reduce, as we discussed before in the previous diagram. MMF intestinal absorption inhibited by administration of proton pump inhibitor. You should put 1 hour or 2 hours at least between proton pump inhibitor, PPI, and acid cholestyramine, sevelamer, and oral ferrous sulfate. This is the most important key or home message also. MMF intestinal absorption reduced or inhibited by co-administration, PPI, acid cholestyramine, sevelamer, oral ferrous sulfate. الناس اللي بتاخدوا حديد بعد الزراعة. Some studies have shown that co-administration of PPI and MMF may result in lower mycophenolate acid exposure and increase the risk of acute rejection and also neutropenia or leukopenia. Enteric-coated is less affected by co-administration with the PPI. This is the patient who are on PPI, they use enteric-coated mycophenolic acid sodium is preferred over MMF. Patient with obligatory PPI with ulcer disease, with any GI gastritis or chronic gastritis, whatever. Patient tolerated neither MMF or enteric-coated mycophenolate is not used in female recipient in childbearing age unless they are on long-acting contraception. Is another important home message for you. Have undergone a surgical sterilization process procedures or have absolute infertility, we can use at that time. Mycophenolate is teratogenic, don't forget that, for any patient childbearing. الفيميل اللي هم ممكن يحصل لهم حمل اثناء الادويه دي، اثناء تعاطي هذه الادويه. And its use is contraindicated in pregnancy. Thus, in this patient, azathioprine is preferred, which does not seem to have detrimental effect on fertility or pregnancy. Mycophenolic acid not metabolized through cytochrome B3 enzyme system, thus and the multiple drug interaction seen with C9, no interaction with the C9, and cyclosporine lowers the mycophenolic acid concentration by decreasing the intrahepatic recirculation, as we mentioned before in the diagram. This interaction is not seen with tacrolimus or sirolimus, and the maintenance dose of MMF is typically 500 milligrams to 100 twice daily. MMF, as opposite to azathioprine, can be administered with allopurinol without dose adjustment, as we mentioned before. Steroid, we have this mechanism of action. Steroid to impair gene transcription of all regulatory cytokines, as we see in our diagram. This block cytokines gene transcription and inflammatory inhibit translocation of NF-κB and inhibitory activity of dendritic B cells, well-known side effect, metabolic effect on the bone, osteoporosis, avascular necrosis, cataract, long-term use, cosmetic, as we know, weight gain also. Initially used as a replacement therapy for bilateral nephrectomy and reversible acute rejection, and now used as a pulse for acute rejection and induction protocols, and we are using in many GN cases. Corticosteroids inhibit the nuclear factor KB transcription factor necessary for expression of several cytokines that are integral for T cell activation. Immediately post-transplant, hydrosome salpinrazole is used, followed by rapid taper to 5 milligrams as a chronic use. Corticosteroid patients who are low immunological risk, we can use rapid tapering. For that patient, the side effect of high steroid, as we mentioned before, osteoporosis, necrosis, impaired wound healing, hyperlipidemia, glucose intolerance, and the psychopathogenic effect, whatever. Latest steroid withdrawal significantly increase the risk of rejection. Don't do withdrawal, just keep your patient on minimal dose, special conditions that may require modification therapy. Patient who have biopsy-proven calcineurin inhibitor nephrotoxicity without acute rejection, discontinue calcitonine and switch it to either M2 or sirolimus or ferolimus or belatacept. Patient who develop other serious effect, neurotoxicity, thrombotic microangiopathy due to C9, first reduce the dose of C9 to 25 or 50%. If the adverse effect persists in spite of the rejection, discontinue calcineurin and switch to M2 inhibitor, sirolimus, ferolimus, or belatacept. This is the other key important home message for you. MTOR, sirolimus, or ferolimus, these mTOR inhibitors are by binding to FKP to inhibit cell cycle. Also, another mechanism, sirolimus, ferolimus. This macrolide also isolated from streptomyces in 1970, used for many years as laboratory markers for proliferative fermenting proteins, confirmed clinical efficacy in the reduced acute rejection 1991, improving chronic graft dysfunction and calcineurin sparing agent, the immune system homeostasis for between risk of rejection and infection or malignancy. You should balance between all this. And these mTOR inhibitors will go to mammalian target of rapamycin or cell cycles is a mechanism shifting from C9 to emitters. Conversion of C9 to emitters inhibitors among renal transplant recipients was evaluated in a systemic review of 29 randomized trial. Patient who converted from C9 to emitters inhibitor within 1 year post-transplant have higher GFR, had higher GFR at 1 year compared to those who remained on C9, better GFR, with the sirolimus or everolimus or emitters inhibitor. However, there was no difference in graft survival, and the patient who switched to an emitters inhibitor had higher risk for acute rejection to up to 1 year post-transplant with hazard ratio 1.7%, as well as a higher risk of dyslipidemia and infection and proteinuria. Binding to FKP, same target of tacrolimus, inhibiting main target of rapamycin, preventing cytokine-dependent cellular proliferation by blocking progression from G1 to SFS, anti-fibrotic properties, less nephrotoxic compared to the C9. And the action of sirolimus here, the same, he will go to FKP, but this is another way, not the calcium urine, will go to emitters inhibitors and inhibit cell proliferation. Sirolimus we are using was once daily, should not be taken at the same time with cyclosporine 4 hours apart at least to increase area under the curve by 230% of sirolimus if taken together. And if taken 4 hours apart, only the area under the curve will increase just only 80%. That's acceptable. To avoiding toxicity can be taken with tacrolimus metabolized, but cyclosporine need to be 4 hours apart. Take care. This is another home message for you. And this is a trick of how can you use this medication and play with the maintenance transplant medication. With the cyclosporine, sirolimus or everolimus should be taken 4 hours apart. If with tacrolimus, you can use together, metabolized by cytochrome P40, 450, and long half-life around 30 to 62 hours. Just monitoring maybe weekly and monitor the drug level. Also, same tacrolimus. early trial قالوا لك 15 30 most recent trial that's 4 days زي التاكروليماس sirolimus synergistic nephrotic system combination with C9 hypokalemia hypomagnesemia delayed recovery from ATN impaired wound healing leukopenia thrombocytopenia hyperlipidemia pneumonitis proteinuria tubular proteinuria decrease lymphocyte integrity. This is a side effect of sirolimus. Thrombotic microangiopathy, especially in combination with the C9 malignancy lowest because anti-angiogenesis. We can use incapacity sarcoma will shift the patient from C9 to emitters for anti-angiogenesis and incapacity sarcoma to transfer to emitters inhibitor. Will I read this slide again? This is the most important slide and home message and key point for clinical experience, how you can deal with this maintenance immunosuppression post-kidney transplant. We have this synergistic nephrotoxicity in combination. In combination with the C9 tubulotoxic, lead to hypokalemia, hypomagnesemia. This with C9. Delayed recovery from ATN, impaired wound healing, user after 3 months from kidney transplant is better. Leukopenia, thrombocytopenia, common side effect, hyperlipidemia, pneumonitis, proteinuria, tubular proteinuria, decrease lymphocyte integrity, TMA, especially in combination with C9 malignancy, lowest because anti-angiogenesis, you can use incapacity sarcoma. In patient with life-threatening infection, how you can deal with your maintenance immunosuppression patient with life-threatening infection now. Withhold all immunosuppression will be hold except low dose steroid stress dose. I will give steroid stress dose as an hydrocortisone or methylprednisone. Don't forget 5 milligram equal 4 milligram methylprednisone or 20 milligram hydrocortisone. Restart is a C9 within a week from the time withheld, but discontinue anti-metabolite and the patient will be established. Patient with moderate infection who can require admission for IV fluid withhold one agent like anti-metabolite, MMF or azathioprine. Usually the agent is hold for 4 to 6 weeks and restart by 50% of the dose that was administered prior to infection. In patient with recurrent infection, discontinue anti-metabolite until patient to clean from this infection. Some clinician just also decrease steroid also among patients with moderate severe fungal infection. Patient who became pregnant, don't forget the childbearing female, because this will be disaster in your career. MMF is mycophenolate sodium emitters inhibitor. All this should be avoided during the pregnancy and the patient who may become pregnant or become pregnant. Also listed at the category D in pregnancy, azathioprine has been safely used in pregnancy and GM patients. Cyclosporine and Acrylemus and prednisone appear also to be safe in pregnancy. Pharmacokinetics such as volume distribution and metabolism are altered with pregnancy, and the drug level required to be frequent monitoring and dose adjustment is another critical home message for you in your clinical follow-up during your maintenance immunosuppression for your patient. Patient or non-compliance on the therapy, non-compliance is a risk factor for rejection and allograft drops. Thus every effort should be made to identify the non-compliant patient early and provide them with appropriate counseling and assistance. In a patient who are known to be non-compliant with therapy, a modification of the maintenance immunosuppression therapy regimes to simplify dosing or reduce pill burden may improve adherence. An example, sirolimus or belatacept we can use monthly, or sirolimus once daily. We can use this, any medication can be taken once daily, or advagraph also once daily. Alternative regimen and extended release tacrolimus, as we mentioned, advagraph and the prednisone already once daily. Deciding on an alternative regimen must be made on the individual patient basis, considering factors such as adverse drug reaction, drug interaction, efficacy, and convenience and cost of the medication. In renal transplant recipients who are considered to be a high or low risk for acute rejection, it's recommended to start maintenance regimen consistent with stable immunotherapy with calcineurin, antimetabolites, and prednisone rather than alternative regimen with grade 1B. Among the available CNI, tacrolimus rather than cyclosporine grade 2B is recommended. Tacrolimus associated with decreased acute rejection rates and is greatly better tolerated than cyclosporine. Instant release tacrolimus tablet rather than immediate release formulation is preferred because equal efficacy and fewer adverse effects of tremors, alopecia, and neurotoxicity. Tremors, alopecia, neurotoxicity like inversus. Among the available antimetabolite agents, suggest administer mycophenolate MMF or intercoated mycophenolic acid rather than azathioprine grade 2B. Despite the increased cost, mycophenolate is preferred over azathioprine because of its superior ability to prevent acute rejection and its better side effect profile. Enteric-coated myfortic is preferred over MMF. Silsep. Enteric-coated myfortic is similar in efficacy and safety and may be associated with GI side effect in certain group of patients. Mycophenolate is teratogenic. It should not be used in female student childbearing age unless they are on long-acting contraception, have undergone surgical sterilization procedure, or have absolute infertility. Thus, in this patient, we prefer to use azathioprine. Another is a good home message. Side effect of chronic immunosuppression, either infection by different type, malignancy, toxicity, metabolites, as we mentioned, diabetes, hypertension, cosmetic hirsutism, and acne is among cause of non-adherence. Most of this side effect, the common cause of non-adherence. As we mentioned, hyperlipidemia with sirolimus more, hyperglycemia, C9 tacrolimus more, malignancy, lymphodepletion, C9, and the infection with glucocorticoids and others, hypertension, cyclosporine, chronic disease, cyclosporine, proteinuria, sirolimus. This diagram just shows late allograft dysfunction, and we'll come to this presentation later. The most common cause of late allograft dysfunction is chronic EFTA, followed by recurrence of primary and also with high percent, 14% CNI toxicity and others. CNI free immunosuppression, we can discuss this in potential benefit improve hypertension, glucose tolerance, and renal function. Potential risk acute and chronic rejection for calcineurin free immunosuppression. CNI withdrawal, I think is high risk for rejection and is difficult to be done. Other medication used in transplant, almetuzumab, anti-CD52, and this we don't have more experience with almutuzumab, and this is just a single dose 30 milligram IV, and this is a side effect you can read later. Belatacept also we don't have still enough experience for that. This will work in the CD80 and 86 and the 28 receptors. Is inhibit co-stimulatory factors as we mentioned before to stimulate three signals for QT cell mediated rejection. This co-stimulator blockage here, and this will this is the mechanism of action of belatacept as we discussed before. This lead to inactivation of signals for T cell activation by this inhibition of this signal 2. Belatacept 52 milligram in 252 milligram in 250 over 30 minutes peripheral vein, or 10 milligram per milli per kg, day 1, day 5, and week 2 and week 4. This for the Nevo induction, and this then high or low dose protocol will come to that high or dose protocol like this. But I don't have experience with that. Mild increase in LED and infusion reaction and infection with the CNI. Conversion CNI from belatacept need overlap at least by this weeks and this region. We are not don't have experience. Rituximab monoclonal chimeric antibody against CD20, and we in this approved for treatment B-cell lymphoma, and the desensitization and the treatment of antibody-mediated rejection. And we'll discuss this later. And antibody, we discussed already the antibody-mediated rejection in details. And this is the indication of and this is the dose and side effect. This then intravenous immunoglobulin also we discussed already before in antibody-mediated rejection in details, and we can use this in antibody-mediated rejection already. This is mechanism of action neutralizing circulating antibodies, inhibit lymphocyte proliferation, anti-inflammatory cytokines, 2 milligram per kg maximum of 40 per 8 to 12 hours, even after plaques already in patient with antibody-mediated rejection. And this another notes. We discussed this before in the antibody-mediated rejection. Leflunomide we are using in glioma virus, and it's a replacement of MMA for azathioprine. We can use this leflunomide as a pyrimidine sense inhibitor of dihydro or dehydrogenase. We discuss this in BK virus nephropathy in details. Another depletion of humoral like plasma pheresis we can use in this sensitization, immune compatibility, recurrence focal segmental antibody reaction, and with ideal immunosuppression, less nephrotoxic, less minimal immunosuppression to decrease the cardiovascular infection, neoplasia, and to inhibit rejection and side effect. Final point for you. A variety of immunosuppression medication are used in transplant. Understand mechanism of each medication is crucial to proper use. Medication are used in combination to reduce rejection rate, improve long-term survival, and mitigate side effect. This we have reference here. You can read as you like more. And الحمد لله ونسألكم الدعاء والتوفيق والسداد، وأتمنى يا رب أن تكونوا استفدتوا أي شيء نخدم به مرضانا، ولا تنسونا من صالح الدعاء، ولا تنسوا دائما الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم، عليه أفضل الصلاة والتسليم. ونترككم في رعاية الله وحفظه، ونترككم في رعاية الله، ونلقاكم بفيديو قريب إن شاء الله. السلام عليكم ورحمة الله وبركاته.